Scott, Justin. Welcome to the podcast. I'm super excited to work with the two of you today. For people who are not familiar with you, would you mind filling them in a little bit about who you are and all the amazing stuff y'all are doing clinically?
Podiatrist, surgically trained, originally from Florida with all my training. Now I practice in Maryland. My practice, it covers everything, but a lot of focus on sports medicine now, which is my passion. Background before getting my podiatry degree in surgical training, bachelor's and master's in exercise physiology from Florida State. So that thought process of muscle physiology, exercise science has always been there. I did carry that over into my practice. So I do a lot of biomechanical examinations, gait analysis. It's one of those passions of mine, learning that. And, getting my master's in exercise physiology, a lot of pre-physical therapy students, colleagues, some of them went on to get their PhDs in exercise physiology. So I've always had that inkling of knowledge, and I still try to keep up to date with it as much as I can, transitioning that into having a passion for physical therapy with my surgeries and my sports medicine patients as well.
Awesome. Well, I guess I'll jump in. So just like Justin, I've got my bachelor's in exercise science. I got mine from the University of Florida. So, about 2-hour rivalry going on there between Justin and I, but got my doctorate in physical therapy in 1999 from a small little school in Western PA called Slippery Rock. Realized that, being from New York originally and then going down to Florida to go to undergrad and then going back up north to PT school, I realized that warm weather is definitely something I want to do. So moved back down to Florida, have been here ever since. I've been working with the University of Florida Health System since 2002. I've been fortunate enough to be one of the physical therapists for the Florida Gators for going on, 20 some odd years, with a specialty in lower extremity biomechanics, lower extremity pathology, rehabilitation, surgical and non-operative, with a really focus on foot and ankle. For many, many years, I made my own orthotics in the clinic, and then I've learned to work smarter and not harder, and now I just 3D scan them and send them out and get them brought back in. So, like Justin, foot and ankle is a passion of mine. Gait mechanics, running mechanics, also something that I've kind of done over the years. But yeah, so I've been with University of Florida Health System for a long time, and excited for talking about the sesamoids tonight.
Absolutely. Yeah, the two of you seem like the perfect combo to discuss this. And as we were talking a little bit ago, I know we've all seen a fair number of sesamoid injuries in the athletic populations clinically. And I feel like, at least for me personally, these are not often discussed in the literature, at the conferences, and that sort of thing. And I think that when they happen, they can be very debilitating for athletes. And a lot of times there's this misconception of what it entails. A lot of athletes are under the impression that they'll be back to sport within a couple weeks, couple months. Even if they get a surgery, they think that they're going to be back quick. And I think that there's just a lot of misconceptions around the sesamoid injuries in the foot that need to be cleared up. So for starting off, would you mind just kind of giving us a little bit of an overview what the heck these sesamoids are and what you all do from a diagnostic standpoint? Because I've heard athletes call it sesamoiditis. I've heard them call it bipartite sesamoids. I've heard sesamoid fractures. They always have some kind of new terminology for a lot of times what is very similar in presentation.
Tough, right? I mean, with these usually overuse, repetitive injuries, those sesamoid bones are important, and they're essentially they're supposed to take some of the load off of forefoot loading and running. They act like buttresses, like under a bridge. That's what I always tell patients. They're supposed to be there. So yeah, I mean, when clinically, of course, we're going to evaluate them, and X-rays are there. And what's kind of weird is that, when you do an X-ray and you look at the sesamoids, of course, you're looking for abnormalities. But when you just look at them on an X-ray, they look like they're floating, like, because you can't see soft tissue around them. But when you look at them inside the body, there is so much dense tissue there. Like, they are not floating. They are encased in many structures, tough structures, important structures that help preserve that first MPJ joint capsule. For me, MRI, that's it. The MRI is my diagnostic. That is how I can tell. And then, looking at the terminology, yeah, there's so many different terms there. And sesamoiditis is just a generic term for, sesamoid inflammation. But then with the MRIs, you can get, stress response, bone marrow edema syndrome, and then eventually it can just crack uh, and become a fracture. Um, so yeah, that's essentially how I work it up. I mean, I'll let Scott take over, but doing the actual full workup is pretty entailed on my end. I think a lot of clinicians, sports medicine orthos, non-op ortho, sports med, podiatrists are not doing a thorough enough job of assessing why are these athletes getting this? Because there are many factors at play. There are a lot of structures going by those sesamoids, and a lot of them are starting proximally in the lower leg. And those things you have to address with the perineals, with the gastroc, the flexor lucis longus, the flexor digitorum brevis, the plantar fascia. So many things are contributing. Tibial verum, biomechanics, the gait loading, forefoot loading, pronation. So all those things come into play, and we can talk about how we actually work those up clinically in the office. But diagnostically, X-rays, yeah, you can see some things. MRI, more detail.
I love it. I love it. Yeah, I just got goosebumps because I have finally somebody here sitting across from me that talks my language. I love it. So just to kind of circle on some of those things, like the bipartite sesamoids, basically you're born with those, right? It's a genetic kind of situation in which it looks like you have a crack or a fracture in your sesamoids. The difference between a fracture and a bipartite oftentimes is like you have to look at the edges to make sure it's not a very jagged edge. If it's a very smooth type of surface on the outer side of it. And you've also got to look in bilateral comparison too, right? So oftentimes when you have a bipartite sesamoid, they are bilateral. It's not just a one-sided thing. Not always, but most of the time. So that is an important thing to look at. And then you can obviously look at the imaging and look at the density of the material. Is there edema in the bone? Those type of things will also kind of help kind of give you the diagnostic, impression as to what's going on there. But like Justin said, there's so many important reasons why those sesamoids are there. Like they were put there for a reason. They're very, very important as part of the windlass mechanism as you go to push off and toe off to give you the adequate stability and strength of your flexor hallucis. The flexor hallucis brevis actually is entrenched within those sesamoid regions. So that's super important to identify. But like Justin also said, like somebody's got a plantar flex first, very cavus type of foot. Are they loading that sesamoid excessively? Are they somebody that has a forefoot verum that as they collapse down, they have this little medial whip that really kind of pivots off one of those sesamoids more than the other? Or do they have a rigid foot or a rigid hallux type of situation where they have a hallux limitus or a hallux rigidus, which is really just kind of really embedding that bony prominence on that soft tissue and just kind of beating on it for a prolonged period of time and not giving it any kind of relief as that person kind of pushes off. So many different tibial verum, rear foot position, all of the things that Justin talks about. Do they have a stabilized first ray due to the peroneus longus? Is that able to do what it needs to do to keep that first ray depressed? So many things that I'm super excited to jump into it, Justin, and kind of get his feel on a lot of this. But yeah, it's a really small little thing when you think about it. That's really, really complex in terms of why it's there and how we can kind of deal with it going forward.
Absolutely. And you both brought up so many amazing points from an assessment standpoint, and even just looking at the person from a mechanical standpoint and mechanical structure. You brought up so many different things. How do you go about doing that in a systematized or more of a framework oriented way, if you will? Because as you mentioned, there's a lot to look at, from tibial verum or valgum to the height of the arch and so on that way. And all of these things, as you mentioned, can play into what's going on at the foot. And sometimes you might even need to look higher up than just from the tibia to really get into, what's going on from a mechanical aspect with these athletes that way. So how do you go about assessing these athletes with that mechanical thing in mind? Also, you can go back and forth too. It doesn't have to just go in a circle. So if you want to jump in at any time, just go for it.
Yeah, I defer a lot to physical therapy to do a lot of that workup. I do it, in my clinic. I got that limited timeline of getting those patients in, and I don't think most clinicians, podiatrist, ortho, does enough of a thorough biomechanical evaluation to really assess why. And one of my pet peeves is, when patients have that, and we know it's sesamoiditis, right? Or we know it's a sesamoid fracture. Well, now what, right? And we get tunnel vision. Like we just do. Like we know the sesamoids are there. It's a significant bone that doesn't get a lot of publicity because it's so small and people take it for granted until there's pain there. But we get tunnel vision and we say, okay, we'll offload it, right? Use a cam boot for a couple weeks, let it heal, let it calm down. Give you an orthotic with a cutout, float it, get back to sport. But then what? What if it comes back, right? And then what you do? You rest it, then you offload it again, and then you go back to sport. And the pain comes. No, you have got to figure out the root cause of why these patients are getting that. So for me, yeah, I'm going to do my lower extremity examination, right? And I'll look at their hip internal external rotation and come all the way down, subtalar joint range of motion. We'll look for equinus. We'll endorse, do all those standard things, which, instead of just moving the big toe up and down, we want to really assess all those other things. I make every athlete or every patient that has this walk, right? So, and I think honestly, a lot of clinicians are getting away from that. Physical therapists are great at doing that, but we don't do it enough. We learn it in school, but I can tell you that a lot of us are not doing that. But I make them walk, and Dan, you've seen some of my videos online where I've made patients walk, and I'll record it, and then I love that because then I can slow it down. Like I can slow-mo it and actually see, if there's any kind of abnormality with their gait or with them walking. And from there, as far as diagnostic, yeah, it's not just a foot x-ray. We will look at ankle x-rays. I always, look bilateral, right? I always look right and left. Even if there's only one issue going on, we always look at the other side. I always get limb length x-rays on my patients, right? I always do. I always look for pelvic tilt. I want to see, is one leg longer than the other? And just to rule it out, right? Sometimes, you might be loading more on one side, and that could be a contributing factor why the sesamoid is getting irritated from overloading. So I will do limb length x-rays. So if we have to do adjustments on orthotics for that, we can. And then of course, then the MRI comes back later. As far as like other clinical workup, before those patients, of course, if I can do some treatments before surgery, I will, communicate with, my therapist that I go to, and I do want them to check, the perineals. Like, are we overfiring? Is it overpowering the first ray? Is the posterior tibial tendon overpronating, right? Are we lax there? Is it not strong enough? Again, with the posterior tibial tendon, people are like, well, why? If it could change the vector of how that first ray hits the floor or with the toe off. And, the flexor lucis brevis muscle that those sesamoids have the insertion for, the origin of that muscle actually comes back in the rear foot, but also off the posterior tibial tendon. And people forget that, right? That posterior tibial tendon still has a connection to the flexor lucis brevis muscle, which has a connection to the sesamoid. So those all things are connected and contribute. Even looking at the plantar fascia and the windlass mechanism, right? As we know that deep to the plantar fascia, we have flexor digitorum brevis muscle, and we see adhesions happen. When they get inflamed plantar fascia, is the plantar fascia getting adhesions to the muscle belly deep to it? Is it limiting the muscle contraction? Is it changing the pull of the insertion of that muscle, which also could affect, the sesamoids? There's so much. That's why it's one of my big pet peeves. It really is that we just look at the sesamoid and the first MPJ, and that's it. And that is not it. There's way more involved. But again, I defer to the PTs to look at all of that to figure out, can we change something mechanically when they run, when they load, when they push off, to help minimize the loading on that sesamoid bone.
I think you hit it great. So for me, this is the fun part of being a PT, right? It's the playing detective and trying to understand, or at least hypothesize, why you think the injury is occurring. So getting a good subjective history oftentimes is very much overlooked, right? What has changed in that athlete's more recent history, we'll say, that may have have caused an excessive loading to that. I go as deep as asking, what kind of cleats? Bring your cleats in. Let's look and see where those spikes or the cleats are actually hitting. Are they directly underneath the sesamoid, which could be causing extra compression underneath them? Then you got to look at the toe break and those type of things that may be predisposing that area to excessive load. But like we said also, this can come with a very planus foot, a very flat foot, or it could also come with a very cavus foot. And how you deal with those are very, very different. I'm a big in the belief of the shifting load phenomenon. Oftentimes, we start talking about what is normal mechanics, and I don't know if there is such a thing as normal mechanics. Everyone is somewhat different in their own way, shape, or form. What's too much pronation for one person, maybe not enough for another person. So I'm big in the belief of shifting loads and things we can utilize to shift loads. Orthoses are great for that. Different types of footwear are great for that. You can shift load with strengthening and gait mechanics. If somebody's a 4-foot runner, well, maybe that's not ideal for them in this particular time. Maybe we need to change them to more of a midfoot or a rear foot strike. And we can get into, do I even believe there is a midfoot strike? That's a whole other question for a whole other day that we can talk about. But all of this kind of comes in. I love the fact that Justin talked about leg length. I love the fact that you talked about looking all the way up at the hip, because all of that does play a factor. If there's weakness in the glutes, does the glute weakness lead to increased knee valgus? Does that increase in knee valgus cause more of that rear foot eversion, which causes the actual plantar fascia to collapse and the posterior tibialis tendon to collapse, and then they have to have more of this medial kind of push off because they are not spending enough time to resup, or they don't have enough time to resupinate their foot and kind of come off into a more high gear push off. So all of that kind of comes into play, and for me, that's the fun part, and trying to identify ways in which I could shift the load, because as we all know in sports medicine, especially now in the world of college athletics that I live in on a day-to-day basis, these athletes are getting paid a lot of money, and sometimes putting them in a boot for 6 weeks isn't always the ideal thing to do. And obviously surgery is not always the ideal thing to do. So what can I do to offload that area and allow them to continue to play with less stress on it? We talked about floating the sesamoids, whether it be with a dancer's pad or what have you. That's a strategy. There's a lot of different strategies we can implement or deploy to help us allow our athletes, or my athletes, to stay on the field and perform in a manner that hopefully doesn't put that sesamoid at greater risk, but at the same time allows it to heal up and rest a little bit.
I'm so glad you both brought up the concept of immobilization and just shifting loads away from structures, because that's certainly been the way I've gone with a lot of my work lately. And in relation to the immobilization, the research on what it does to soft tissue structures and what it does to localized bony structures, to me, it's very clear that we should not be putting athletes in boots for, sesamoiditis, if you will, for 8 to 10 weeks. Or, one of my personal favorites was, you're going to wear this boot for 22 hours a day, even when you're sleeping. The 2 hours a day you can not wear it, or practice. You can practice, you can play your games, but everything else you need to be in some type of immobilization boot. And to me, those are things that just need to get shifted towards the past. And Scott, building off the point you made in relation to the subjective assessment, I find this is so valuable in relation to just picking up other pieces that might have been missed previously that way. And a lot of times I can get 80% of what I need just through that conversation, right? Oh, they have a past history of other issues with bone density or bony stress fractures in other regions. Hey, we need to go down that a little bit deeper. Oh, they've got a history of multiple ankle injuries. They rolled their ankle, sprained their ankle 5, 6, 7 times. Justin and I did a podcast on that in the past, how that rolled ankle is not just ice it and get back on the field the next day. There's a lot more to it. And as you mentioned, in relation to the anatomical structures, the posterior tibialis muscle in particular is of particular importance with the sesamoid injuries. And that's something that goes hand in hand with some of these other ankle conditions and instability moments that we tend to see that way. But again, if we don't look, then ultimately we're not aiming as close to a sniper rifle type precision as we should be here. Obviously, there's a lot of different ways these can get injured from a chronic standpoint, all the way up to acute injuries that way. Have you noticed any trends in your clinical practice from mechanisms or certain types of athletes presenting with these more than others, maybe whether that's lacrosse or runners or dancers or anything of that sort?
I tend to see a lot with my lacrosse and my soccer players, and even some football players. It's the minimalistic type of cleats, the really kind of small low boots, we'll call them, that tend to be very narrow, tend to be unforgiving with regards to any type of cushion and support, and have those spikes in maybe some spots on the plantar aspect of the foot that aren't ideal for that particular athlete.
Yeah, I recently had one patient, lacrosse. Knowing their position is important too. He was at attack, right-handed, right foot sesamoid fracture. So he was pushing off on that right foot when he attacks in summer camps and just so many games and practices through the summer. And eventually that was his injury. It was overuse, but yeah, knowing the position as well. Soccer for sure, yeah, not much support there, low, minimalist type of cleat. But yeah, I mean, I honestly, I don't think I've seen it in basketball too much, but lacrosse is big. I have seen it in baseball, and soccer and lacrosse. I think those are probably the top 1 and 2 for my practice.
And you mentioned from a conservative management, you both mentioned orthoses, you both mentioned possibly using a dancer's pad and just overall offloading that area however you can that way. And I've seen a lot of other strategies to do this, from taping and casting techniques to other variations that way. Is there anything that you feel is maybe overrated or maybe on the flip side underutilized in shifting load away from these structures in order to help keep these athletes on the field? Because I mean, Justin, I see you post it all the time, and Scott, I'm sure you get it all the time at Florida as well. A lot of these athletes are under pressure to play games, and it might be their last chance to get that college scholarship, to get seen by that coach and end up going to the University of Florida on a scholarship. And they don't want to miss that opportunity. So obviously pushing them through that any way possible is of the most importance for us. However, we have to know what thing we need to reach for, what tool in our toolbox we have to reach for in order to make that a success for them.
I think I'm sorry, Justin. I mean,
Oh, go ahead. I
was like, with an orthotic, you can, you're robbing Peter to pay Paul, right? So, with an orthotic, I can definitely get somebody off the sesamoids. Like, there's no denying it. I can alter their mechanics such that their big toe doesn't hit the ground. But what risk am I putting them at for other things? So it's that balancing act, right? So, the most, I think, minimal or least invasive, a simple little dancer's pad tucked away on their sock liner works great. But if I do really need to offload them, I can varus post them from the 2nd to the 4th or the 2nd to the 5th. I can rear foot post them. There's a whole host of things I can do to kind of really shift where they're putting their pressures, but I gotta really be, taking to mind their sport, their type of movement patterns they're going to be deploying, and it's a little bit of a tightrope walk that you have to take there.
I'm curious, Scott, just in general, do you have any idea, like, percentage of athletes that have orthotics? I'm curious.
So I this has really shifted for me over the years. I've been doing this 25 years, and at one point somebody came in with flat feet and orthotics, or there are certain coaches, let's say, that really want all their athletes to be prophylactically in orthotics, and I don't necessarily think that. I think the big thing about orthotics, even if you do prophylactically, more than anything else, I think that you're doing is especially at Florida, where we're a certain school, contract with certain shoes. Not everybody's foot fits well into a certain type of shoe, so I think what we're creating is a custom footbed a lot of times, which I think can offer some comfort. But typically, I think, with me and my athletes, I'm a little bit more willing to put them in an orthotic, because I know they're only going to be in the orthotic for 3-4 years while they're here at the University of Florida. They're doing their strengthening. They're not wearing them all the time, especially in the case of like a lot of soccer players and lacrosse players. They may wear it when they're in their spikes or their cleats, but as soon as they come out of them, they're walking around campus with their normal sneakers without them. So I'm not really worried about their foot getting quote unquote weakened by wearing the orthotics. I think that's really overplayed. I think, as long as people are doing the adequate foot strengthening, working on some balance, working on their foot intrinsics in the weight room and doing those other things, then I think that gets overplayed. But
Right.
I'd say we tend to use them a lot just because, again, I tend to see them a lot because, again, anybody that kind of deals with a foot issue, we're not saying we're automatically putting them into an orthotic, but that's one of the tools that we use to get them maybe playing a little bit quicker while resting that injured tissue a little bit from the get-go. So certain sports more than others, but there's, I'd say maybe, I don't know, 20% if you look at all of our athletes at the University of Florida that are, and probably even less, if you really think about it. But, I see a high volume of them because I'm seeing a lot of foot and ankle stuff myself. So, yeah, it's hard to say exactly, but I'd say if, quarter, fifth.
I think what one population we do have mentioned earlier was the dancers.
Yeah.
They have no option, right? It's hard. A lot of them barefoot. Yeah. Gymnasts, yeah, hard, very difficult. I mean, what are you going to do with that? So those are tougher. Yeah.
Yeah, but you rest them when you can, right? That's what we do. We try to rest them when you can, and then realize that when you can't, and see how it goes.
But and when we say rest, we still mean we're working on other parts of the body, right? So, exactly, right. Resting that foot, but yeah,
Correct.
doing other things, yeah.
Correct.
Absolutely. And as you're working on other things that way to kind of help address some of these different issues and hopefully leading to a successful conservative management of the case, are there any common traits that you've noticed amongst successful conservative management that you've had that way? Any certain, regions that you focus on or certain exercises or strategies that you lean into more than others per se?
You want me to take this one?
Sure.
Sure. I think again, it depends on the cause of the injury, right? Is somebody have a hypermobile foot, so therefore we're going to really work on stabilization, really kind of work on trying to resupinate the foot, trying to really control, make a more of a rigid kind of stable type of platform for that person to push off of, or do they have a really rigid foot, which in case we're going to work on mobilization, getting things moving better, cushioning maybe a little bit more. So I think it really, really varies. I think one of the things that gets really overlooked is the stability of the first ray. And so that's something I like to focus on a lot, especially if somebody's got a hypermobile type of pronatory type of gait pattern. So really working on the pronates longus, stabilizing the first ray, making sure we can keep that down, because just like a seesaw, if the bottom or the distal segment stays down, the arch or by the sustentaculum tali kind of stays high. So those are some of the things that I like to focus on. I do a lot of talocrural mobility, do a lot of soft tissue mobility. You got to, like Justin said before, working on the posterior chain, making sure the gastroc soleus complex is moving the way that it should, making sure the hamstrings are doing what they should as well. So all of that kind of plays into it. But again, it all comes down to a good diagnosis as to why this is occurring in the first place.
Absolutely. Yeah. And building off that point, one of the things that I started to do on an assessment that just blew my mind was I'd, instead of assessing just straight dorsiflexion, I'd kind of lock them into a subtalar neutral position and have them dorsiflex. I was amazed at the difference when I did that versus not do that, how limited they were when you hold them in that neutral state that way. And it's crazy the ways that these athletes will find to compensate and hide their strategy for movement, if you will. They will do anything they can to get quantity over quality without even knowing it, if you will. And obviously that makes these rather complex to manage. And, I've had some that unfortunately did not do well from a conservative standpoint and ended up needing surgical procedures from people like Justin. However, I've seen this wide array of how we manage sesamoid injuries, from just removing the fractured bone to Justin's technique that is absolutely incredible. And every time I hear about it, I get more excited. So just from a surgical standpoint, what are you guys seeing, doing, and what kind of things do we like versus not like in managing the sesamoids from a surgical standpoint?
Yeah, with you're always looking at timeline, right? When do you throw in the towel? That's always tough for us. And look, once we always look at each patient individually, right? We don't like to generalize, and that's why with research studies it's kind of hard because we are generalizing. But what year in high school are they, right? Yeah, are they on crunch time? Is it junior year? Is it recruiting year? Is it showcase? And what month are we at with this injury? Are we getting anywhere? Is the repeat MRI showing any improvement? Or are we stalled, right? Are we hitting month 4, right? Are we hitting month 5? What time of year is it? So all those things do come into play. But, as far as surgically, bottom line is sesamoid removal has been tried and true. The research shows that it can do very well, right? It is not, you know, it's not a horrible surgery. It's not a fun surgery, but when you look at the research, it's just so hard. When we look at the literature review and the research, and the problem is, with research, when I always tell residents is that you always have to go in as a skeptic, and you always got to look for that bias, and if a lit review says a complication rate of 30%, I mean that I've seen some that show that's kind of high for a surgery, a 30% complication rate. That we don't like that high. Ideally, if you can give me 10% or lower, that's ideal. But we've seen some cases, literature that shows a 30% complication rate, chronic pain, foot deformity, changing the angles and the hallux bunion angles when you remove some of them, getting stiffness of the joint, losing push-off power. So all those things can come into play, as well as chronic pain. But and then you look at some research studies that show, well, with one surgeon's retroactive review of his cases, and you had a 5% complication rate. Well, that's a good surgeon, right? Or, 5%, I mean, maybe that surgeon is just really good at them, but the entire US population of surgeons aren't all going to be like them, right? Unless they all sent to him or her. So, when we look at generally, it's just tough. It's so tough. And then you're looking at the patient age, right? When we're lumping these research studies, and average age is 40. Well, some of them aren't college athletes, and some of them aren't professional athletes. They're high-level recreational athletes, and it's still different. And then when you look at, there's some studies out there that show an average age of 15, right? And what are we doing for those? So it's tough to dissect. It really is. And you can get a sesamoid removal and do great. And you can get one that just is stalling and just not doing well. I have removed sesamoids, in the past, and I have seen complications of my own patients. And, when I decided to figure out a different way, when everything else failed, and even when we do surgery, we still want to do therapy and still work on all that kinetic chain stuff to help them. Before it became a fracture, a lot of times it was just bone marrow edema. It's bone marrow edema. It's such a small bone. There's not a ton of blood supply to it. And the pressure, the intraosseous pressure just increases and increases in that small confined space, that the bone gets so deteriorated that it eventually just cracks. And that can happen in the talus. It can happen in the calcaneus, the navicular, the metatarsals. I mean, that's why we get stress fractures. They start off as bone marrow edema first, and then the pressure in the bone increases, the bone gets weaker, and then the turnover of osteoblast, osteoclast gets disrupted, and then it can crack. So, when I was treating some, bone marrow edema of the talus, we would just wait and wait and wait. Month 1, 2, 3, 4, 5, 6. And with college athletes, they don't have time to wait. Professional athletes have no time to wait. We got to figure out, what are we going to do? Because there is research that shows that bone marrow edema can resolve on its own 6 to 12 months, right? You get an athlete waiting 12 months for that to resolve. No way, right? And even high school athletes, what? I got to wait out 2 fall and spring and summer. We got to figure out a different way. So, we started doing core decompressions, right? How do we release that bone marrow edema? Well, we core drill it, right? We drill into the talus. You do it in the tibial plateau, in the knee, in the femur. So we were doing core decompressions, right? Can you disrupt that altered cycle of intraosseous pressure and get it to release, stimulate that bone to somehow get a healing response? And then I think, well, if we can do that with small drill bits in the talus and the navicular, and hopefully just speed up some recovery without being too invasive, why not try it in the sesamoid? And that's what I did. I literally just took the bigger drill bits and made them smaller, and would fenestrate and core decompress into the sesamoid. And I would take bone marrow aspirate from the calcaneus, harvest it, try to get those mesenchymal stem cells, and that's a separate topic, but I'm going to do everything I can to try and stimulate something for that athlete. And maybe it can, differentiate into osteoblast and get some bone healing. And sometimes it's a curettage, scrape the fracture site, and then core decompress and inject into that area and just fingers crossed. And I've done it quite a few cases now, and no literature on it, but I need a bigger patient, uh, number. But they've had good success. And the risks, honestly, they're small, they're minimal. I mean, I'm doing most of these either under fluoro, but minimal incision or just percutaneous now.
I think those are great options. I think you'll agree with me. I think before going in and doing any type of surgical procedure, you want to make sure that they failed, at least tried conservative intervention, right? So, aside from just offloading them, what can we do to kind of do the same things that you're talking about, And I think one of the areas that I've really started to dive a little bit deeper into myself. By no means am I an expert in this, and the research really hasn't come out completely in full support of this. But I think shockwave therapy is one of those things that I think will do a lot of the similar things that we're talking about here. Really trying to stimulate healing, kind of break the cycle. I've had some success in some other regions of the foot, and even in the talus or what have you. In some of those situations where you kind of try it for a couple of sessions. You're not doing it all that much. You're doing it maybe 5 or 6 times. Once or twice a week, and you see where you're at. I've seen some people actually try some needling into the actual bone, do like almost like little tenotomies with a needle to try to stimulate again some of those type of healing situations. Couple that with the strengthening and everything else, and some time. We shouldn't overlook time, but do we want to wait 6 months, 8 months to kind of get this to subside? I think that's a little bit excessive as well. So it's that balance. And Justin mentioned certain physicians and surgeons having a complication rate of 5 or 10%. Probably they're picking their patients really, really well, right? They're not going in and plucking them out on everybody. They're making sure that the ones that have really failed conservative intervention are the ones that they've kind of picked. They look at other factors like, are they a smoker? Are they obese? Some of these other, what's the nutrition like? All of these other things that kind of come into play that help make that clinical decision a reality need to be addressed.
Yeah, I think that's a good point with the shockwave. I mean, what we with plantar fasciitis, Achilles tendonitis, what we know is that, when you hit the 8-month, 9-month, 10-month mark, the body starts to give up, right? We know that. Like the body always wants to heal itself. I tell patients that all the time. You break a bone, your body will fix itself without any doctor, to a degree. But then you get that cycle where it becomes chronic pain with no healing. The brain just says, live with it, right? And with that thought is, how do we break that cycle, and how do we create that old injury and create a new injury? And that's where shockwave came in. That's where we doing these plantar fascia, fenestrations, and it's same thing with core decompressions. We are trying to break that cycle so the next morning that patient's brain realizes something different happened down here. Let me go investigate and figure out what that was. And then that's why I also add on the bone marrow aspirate and the mesenchymal stem cells, because maybe that's there ready for that brain to know, like, you know what? Let me figure it out. Let me see if I can get some healing response there, because something changed, whether it be shockwave, needling, core decompression.
Mm-hmm.
To that point on the needling, shockwave, and so on that way, where do you draw the line on that? Do you do one single session, 10 sessions? Because I've seen people all over the map with that, and I've had a lot of patients who come to me and they're like, well, I tried it once. What's one more time going to do for me? It didn't work the last time. They're expecting immediate relief. And I think this is an area where educating the patient on realistic expectations and timelines is so essential.
I think with the needling, that's one of those things where I think you may find almost a little bit more of an immediate relief, especially depending on what you're needling too, right? Because we talked about the flexor hallucis brevis tendon being in that area. Is that actually the cause of the problem?
Mm-hmm.
So you got to consider that. I think with shockwave, I think the results tend to be a little bit slower potentially, but still not very long. I think you should know within a couple of, like I said, 6, 7, 8 sessions, whether or not this is working or not, or helping or not. So I don't think it needs to be drawn out for any type of, 6 months, 8 months, anything along those lines. pretty quickly. And again, what type of shockwave unit are you using? Are you using radial? Are you using focal? What's the intensity? Shockwave should not be a very pleasant type of experience. It should be uncomfortable. Something that the person can tolerate, and it shouldn't be. I've had it done to me, and it's I call it like the deepest toothache you ever felt. It's just a weird sensation, but it shouldn't be comfortable. And I think I've heard a physician that does this quite a bit say, if you don't feel uncomfortable, you're not doing shockwave. So I think there's part of that. So you got to make sure it's being performed by the right person in the right hands, and that you're hitting the right spot. But yeah, I think a couple of sessions. I wouldn't expect magic after one session.
Yeah, no, I'm right there with you. And Justin, just going into that technique that you described with the core decompression a little bit more, post-operatively, everyone always talks about, oh, well, there's the protocol and there's these different things laid out for me that have not changed in 20 to 30 years. But in your case, obviously, you're one of very few people, if any others, doing this technique that way. What kind of things do you look for? What kind of things do you value in the rehab providers acutely? And what kind of things, from a timeline standpoint, are you looking at for the first month or two post-operatively with these?
Yeah, for 2 weeks, I still wanna prevent range of motion of that big toe. I just want the sesamoids to sit, right? Let the body just try and find its sweet spot to heal. And then after 2 weeks, I want them moving, not crazy range of motion, but we want to start moving. Of course, working on everything else, the gastroc and the lower leg muscles, the hips. But, with removing the sesamoid, I mean, when we remove those bones, there's a huge defect in the plantar plate and the ligament in that all those structures, and it's traumatizing postoperatively. So there's pain, there's swelling, and having that defect there, the joint effusions that occur there happen significantly. So with my technique, we're avoiding that, right? We're avoiding any kind of crazy trauma to the joint capsule area. So it's allowed my patients to get to PT, I think, a little bit quicker, and start to mobilize a little bit faster. But still, it's still a bone. We still gotta, have to let it heal. But again, it's having the PTs communicate. That's the big thing. And I got 3 messages just right now, from PTs regarding patients. So it's that too. It's just, how sometimes you guys will contact a surgeon and it's crickets for like a month. But no, I prefer that they reach out to me, and it's both of us gauging when we take it to the next step, right? More so, I think, on the PT, but usually I will give a hard, like, all right, this looks good. Now it's up to your physical therapist to get you back to the sport. And I usually will tell them, all right, free game, go.
I'm a big fan of blood flow restriction. Early on with these type of things, just in general, because again, you don't want to. You're probably fair to load, your calf. Depending on how you do it. Weight bearing, obviously not, because you don't want to be pushing too much off your big toes and coming up. But I'm a big fan of blood flow restriction. Start with bands, and you can start that fairly early. 2-week mark. Making sure that the wound is closed and everything looks good, and then you kind of take it full steam ahead from there. But we really haven't talked about some of the other problems that occur with the sesamoid removal, right? So it's really deemed non-advantageous to take them both out, right? Because again, then you get a really unstable first, which is problematic. And then the other problem that you have to really guard against is if you do take one out, what type of alignment issues, because now picture somebody pulling back on a horse rein, and they're pulling back with the 2 ropes. The horse kind of pulls back nice and evenly, but you now only have one pull. Which way does the horse pull, or the other one, which way does the horse go? And so you've got to balance that, and sometimes there may be some alignment issues that occur as a result of having one of those removed. Now the patient may be fine with that as long as they have no pain, right? So I think you got to wax and wane that a little bit, or weigh that the pros and the cons there a little bit. But to Justin's point, those bones were there for a reason, and if you don't have to take them out, why are we taking them out? But sometimes I think I have a patient right now that had it taken out and is doing fabulous, like no pain, knock on wood, no pain, 7, 8 weeks out, lacrosse player doing great. And that's what you hope for, but it's not always the case. And I just think you need to be mindful of some of those alignment issues that could result, and some of the other things that could present itself as a result of not having the normal stabilization, we'll call it, of that toe at push off.
Right. I think, if you're looking at like a junior college player, get the sesamoid removed, red shirt, plays senior year, down the road, they could get deformities, but then they're done with their college career. I mean, they might go pro, but let's just assume that it's just college. And then if they're 14, remove a sesamoid bone. I'm concerned, right? I'm a little cautious because you don't want that bunion or that hallux varus or valgus deformity to slowly develop at 15, 16. Next thing you know, they're 19, a sophomore in college. The mechanics of that first ray are completely off because they had the sesamoid bone removed, 6 years prior, 5 years prior. So age comes into play too on some of that. But yeah, I had a college lacrosse. She graduated. She's 25. For Achilles pain, she came in, but she played college lacrosse. She had her sesamoid bone removed. It did fine. Yeah, she finished out her career. But yeah, we do have to think about the ultimate mechanics and the actual structural changes that can happen on the first ray with removing them. That's why with young teenagers, I don't know, I'm just so cautious about doing it.
Yeah, I mean, going back to your analogy before from the bridge buttress, it's like if you take one off, what happens to the other side of the bridge, right? And going back to what Scott mentioned about BFR, that has been one of the key tools that I've seen succeed for a lot of the patients that I've seen struggling from some of these different injuries where sesamoid gets removed and we're 6 months out, we're 8 months out, and we're still in pain, still not sure why we're not progressing forward. I do a lot of BFR with them, and I think the analgesic response that they get from that, in addition to some of the hormonal signaling that occurs as well, just going back to the underlying physiology, is something that is, of benefit, if nothing else. I also do a lot of isometric work with them because the way I look at a lot of these cases is the nervous system is still trying to figure out what the heck is going on because it knows something is different, but it's not sure what, it's not sure where to go. So I find a lot of the times if we just make them do a lot of long duration holds in some of these different positions that they're going to spend time in, a lot of long duration, overcoming ISOs in some of these positions where it's like, hey, you're going to push your leg into this to create a frontal plane force, and your foot is going to your other foot is going to stabilize on the ground, and just try and figure out how the heck do we stabilize against this over and over and over again. Starts to get something going, but regardless, even with interventions like that, there's still a number that are just really, really difficult to work through. And, unfortunately, I've seen some of these take longer, closer to a year before they're actually able to return to sport that way. And I think it's one of those things, going back to what you talked about before, from the individualization and the importance of the assessment. It's like, you just keep going back through everything over and over. Hey, did I miss anything? Was there something else that we could be doing here? Because obviously these cases are super frustrating when they don't go as planned, and I don't have a foolproof playbook to navigate them when they're not going as expected yet. But I think we're getting closer every case, every day.
Agree.
Is there any other insights that y'all have just from those cases that maybe haven't gone well from a sesamoid removal that have really been beneficial to you? Or your patients, I should say.
Amputate.
Just cut it off, start new.
Yeah.
Now, the other thing that comes up a lot when I'm talking with clinicians is they ask me what my return to sport protocols and parameters are. And, they'll cite all this literature on the knee, and it's great. And then they go, but what about the foot? Do we still do hop tests? Do we still do strength tests? And at least for me, and this could be the totally wrong thing to do, but I still do dynamometry for the ankle, inversion, eversion, dorsiflexion, plantar flexion. Yeah, it's not perfect, but I'd rather get something instead of nothing. And I still like doing the plyometric assessments, your hops, your jumps. I like incorporating the force plates. And for a while, I was even playing around with some EMG type stuff. And I think that it's important to have some kind of framework in place when it comes to this return to sport conversation, and not just saying, well, you've been pain free for the last 3 months. I think you're good to go. What kind of things do you two look at to help your athletes decide when they're able to go back to sport, and then what that progression looks like once they go back to sport? Because obviously there's a huge difference between returning to play their sport and returning to their desired level of performance after injury.
Those are great questions. Great
Yeah.
questions.
I'll defer to Scott on that one, because with me, like it basically mine is pain, range of motion, but like I don't have all that assessment. So I say, for physical therapy, let them decide.
Yeah, I think pain, range of motion are obviously the bottom basement thing that you need. And, obviously at Florida, we have the ability to look at, isokinetic testing, force plate testing, all the cool, movement analysis, 3D cameras, all that great stuff, right? But at the end of the day, it's progressing them through the activities that they're going to need to do, and how do they perform those activities, right? So you go from, non-weight bearing to weight bearing, bilateral to unilateral, basic strength to power to reactive strength to speed. And are you check along the way, right? So, by the time you're about ready to strength test them, you have, or not even strength test them, but do a functional test with them, you have a pretty good idea where they're going to be based on some of the activities that you've asked them to perform to that point. So I don't want to downplay the importance of functional testing, and 80% of the contralateral side and all that good stuff is super important. But at the end of the day, if you're a good therapist and you're gradually progressing patients back to the activities that they're going to need to be doing, you're on the path, right? And I go, test. If you're not testing, you're guessing. I get it. But again, you'll have an idea as to when your athlete is ready to go, based on how they're moving and how they're performing on some of the low-level tasks you're asking them to do. As you make those tasks more difficult and more challenging, how are they responding? Are they getting sore? Are they favoring it? Are they landing? Are they pushing off appropriately? All of those movement qualities that we want to look for and get, force data on and strength data on is great. And it's really, your eyes can only do so much. Some of those other means allow you to get a little bit more into the details. But I think generally speaking, you just make your progressions just like you normally would, and at the end of the day, have some type of criteria, whether it be force plate or what have you, at your disposal to kind of make that final jump. But I haven't seen anything in the literature that says, following a sesamoid removal or a sesamoid problem, you need to have flexor hallucis brevis strength at 80% of the other side. Like, good luck, right? So functionally, what do they look like?
Right. And to your point as well, we are so married to this concept of return to sport being an event on the calendar. Oh, it's this day, I'm going to pass these tests, snapshot in time, and then we're good to go. When in reality, it's a continuum and progression, as you outlined. So to me, it's like if we're constantly moving towards that goal, we don't necessarily need maybe one snapshot in time, because maybe we're assessing 10 different things across 10 different points in time instead of just 5 things on one specific day. And I think that the other piece that comes to mind as well is just understanding the forces at play that these muscles can produce, because I think people think about the foot muscles and they think about, flexor hallucis longus and FHB and so on. And they think, oh, they're just, small little things, they assist, and so on that way. But if you look at the studies, these things produce upwards of thousands of newtons of force. And I believe this might be incorrect, but I believe from a number standpoint, when you look at the forces just within the FHL during MVIC of a toe flexor, you're looking at upwards of 125 pounds per inch of force, or 14-ish Newton meters. It's like, these are extremely high forces. And it's like, you're not going to get here if you're sitting in the PT clinic lifting your leg up and down on the table 3 sets of 10, 6 months out from surgery. So I think once you start to kind of progress back to some of those sports elements, if you will, and Scott, I'd love to hear your thoughts on where the line gets drawn from like rehab to like maybe integration with performance coach on this, because I think sometimes we as PTs like to do a little bit more, and sometimes maybe we could just delegate out to sports coaches, strength coaches, and other individuals on the team as well to help make that final push.
That's a great question. I think a lot depends on, like you said, your setting, your communication, your integration with your strength coaches, etc. I'm fortunate. I work with some amazing strength coaches, and as soon as I can get my athlete integrated into the weight room with my strength coaches, I do it, right? And the reason I do it is because there's so much more to sports than just being, playing games. There's the integration, and there's the other things that are noted or gained by just other aspects of strength training. Like if we keep them out of the weight room, what else are they missing? What other muscles and tissues are they neglecting? So, if they're not going to put themselves at risk, and obviously I lay out certain things they can and can't do in the weight room with their strength coach. I tend to find oftentimes I isolate a lot more, and I let my strength coaches do more of like the compound stuff, bilateral stuff, and I'm sitting there working more on the deficiencies of the one side. But that's further down the line, and obviously, once they're able to walk and do things pain free with both of their legs, and they're squatting and doing those stuff with me in clinic, and I feel comfortable to actually get them doing some of the things with the team and the strength coach, I will. When it comes to running and those type of things, I'd like to integrate them with myself first. We have an Alter G, which is a great little tool to get people running a little quicker. You're able to unweight them a little bit. But for example, with my girl right now that I've got, we got to get her in cleats, and I just don't have the ability where I'm currently at right now to put her in cleats and actually take her out in the field and do it. So what I have her do is she's running with her athletic trainer and her strength coach. And I said, hey, instead of doing 5 200s at 70% with your sneakers, do 4, and then have the last one try it with your cleats. And if that goes good, then a couple days later, maybe do the last 2 with your cleats. And then if that goes well, maybe the last 3 with your cleats, and see gradually progressing that situation so they get acclimated to do those type of things. But yeah, I think the key is your relationship with your strength coaches, what type of setting you're in, and what kind of guide rails you set.
Absolutely. Any unique cases or case studies or case presentations that the two of you have had in relation to the sesamoid that way? I know you've mentioned a few as we've gone.
I'll just say that, same athlete, different sesamoid on each side. One went well, one was a little slower. And so, and you see this with every joint, like ACLs, total joint, total knee replacements, people that have bilateral total knee replacements. One either is really good, and then they go for the second one and it's terrible, or they do really bad on the first one. They don't want to do the second one. The second one goes swimmingly well, and they're like, man, what happened? So you never know.
Right. Yeah. Yeah. You just don't know. You could do the same technique, same staff, same everything, and then for whatever reason, the body's just weird like that.
Yeah, no, that's how it goes sometimes. Guys, I feel like we talked about a lot of different things in relation to the sesamoids that way. Is there anything we missed as we were chatting today, whether that be on the mechanics side, the surgical side, and beyond?
I think so. We hit surgery good. I think, take home point is not to get tunnel vision and just look at the sesamoids in the first MPJ. We got to look at everything that's proximal to it as well.
Yeah, I agree. I think we took the sesamoids, 2 little bones, and beat them to death. So yeah, I think they're interesting. They're interesting anatomy to kind of consider, and I think don't overlook those 2 little bones on the bottom of your foot, because they do have a bigger implication as to how you function, and don't just take them out. They're there for a reason.
Absolutely. Guys, for people who want to find out more about you, your practices, reach out with questions, catch you presenting at a conference, where can they find you all at?
Yeah. Instagram is for me. That's where I'm most active. It's Justin Lewis, JUSTINLEWIS_foot surgery. Website mdfoothandankle.com. Yeah, most people reach out to me through Instagram. I respond, I give advice, and consultations. Of course, I get patients in. Of course, with athletes, yeah, we get them in quickly, of course, because we know time is money.
For me, it's Instagram too, Scott Greenberg .dpt is one spot. I also have a partner that I partner with. That's a chiropractor out in Colorado, and together we're called the Gait Geeks. So we do some continuing education courses and have some podcasts and do some things along those lines as well. And I have a website that sometimes is up, sometimes it's not. It's scottgreenbergpt.com. So Instagram is probably the easiest way to get a hold of me.
Yeah, that's awesome. Link to all of that in the description below. That way, if you didn't quite catch that, you can just click there and see everything Scott and Justin are up to. Guys, this was awesome. Thank you so much for your time and your insights.
Yeah, thank you. Appreciate it.
Enjoyed it.